Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. This webinar, as usual, is brought to you by Mumbai Haematology Group, supported by Sanofi, Janssen, Natco Oncology, Lucien Life Sciences, and Unipath, and very well managed by Perfect Square. I thank team Sanofi, Janssen, Natco, Lucien, and Unipath, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Haematology Group, our faculty for the day, Dr. Ramya Upuluri, Dr. Ruchira Misra, Dr. Uday Kulkarni, Dr. Kanan Subramanian, and Colonel Dr. Uday Yanamandra. All our discussions were themselves very eminent hematologists, medical oncologists, as well as bone marrow transplant physician. And you participants for sparing a Saturday evening, morning, or afternoon from whichever part of the world you're locked in. Our first session will be sponsored by Sanofi, and this will be held from 5:50 p.m. to 7 p.m. And to introduce the faculty for this session, we have Dr. Ramya Upuluri, pediatric hematologist oncologist at Apollo Cancer Center, Chennai. Dr. Ruchira Misra, senior consultant, pediatric hematology oncology and BMT at Clinicals Hospital, Parel, senior consultant and head of department, MRR Children's Hospital, Thane. Dr. Uday Kulkarni, Professor, Department of Hematology at CMC Vellore, and Dr. Subramanian Kadan, Hematologist at Sayadri Specialty Hospital and KM Hospital, Pune. The agenda for this session will be, context setting will be held by Dr. Ruchira Misra from Mumbai. The lecture will be on tackling the holy trinity of engraftment, immune reconstitution, and GVHD, ATG plus PTCY in haploidentical transplant by Dr. Ramya Upuluri, Chennai. We have got panel discussion thereafter, and this will be moderated by Dr. Ruchira Misra, and the panelists are Dr. Ramya Upuluri, Chennai, Dr. Uday Kulkarni from Vellore, and Dr. Kanan Subramanian from Pune. So I stop sharing over here. And over to you, Dr. Ruchira Misra from Mumbai.
Good afternoon, good evening, everyone. Thank you for sparing your time on a Saturday evening. Reason why we've gathered together over here is to discuss about haploidentical transplants. We all know that India is doing very well in terms of haploidentical transplants, and we're kind of becoming trendsetters in this field of bone marrow transplants. However, when we think about haplotransplant, we often worry about graft failure, then we worry about immune reconstitution, and we worry about viral infections post-transplant as well in our patients. And of course, about JVHD, because the more mismatched the transplant, the higher the risk of JVHD. And with both ATG and PTCY or post-transplant cyclophosphamide now coming into the picture, the scene has changed, and we're often very comfortable doing a transplant even with a half-matched donor. So hence today's discussion will be based on half-matched donor transplants itself, and we'll be discussing the role of ATG as well as post-transplant cyclophosphamide, or maybe even a combination of both, to see how we can manage graft failure, how we can manage immune reconstitution post-transplant, and look at GVHD and how to manage that post-transplant as well. As Dr. Khurana mentioned, we have very eminent faculty for this today. We have Dr. Ramya Upuluri, who's at Apollo Hospitals, Chennai. She's a pediatric hematologist, oncologist, a very close friend. And I invite her to speak first on this holy trinity with haploidentical transplants. Ramya, I'm going to hand over the screen and the mic to you. The stage is yours.
Thank you, ma'am. Can you hear me and see my slides, please? Yes.
Could you please put in the full screen mode, ma'am?
Yeah. That's right. I will do that. Okay. So thank you especially to MB Agarwal sir for this opportunity to be part of this seminar this evening. Thank you to Sanofi and Dr. Khurana, and thank you Ruchira ma'am for including me as part of the discussion this evening. So I will very quickly, I won't take too long because the discussion will be more interesting what Ruchira ma'am has lined up further after this. So we'll talk about combination of, ma'am already has given you a Dr. Ruchira has already given you a sort of background of why this seminar is being held and why the topic is important. So the topic is on low dose ATG plus post-transplant cyclo in haplotransplants. We know that there are mainly, in general, three methods for doing a haplotransplant, either the Hopkins method, which includes the post-transplant cyclophosphamide on day +3 and day +4, the MAC PTCY, the non-myeloablative method, as well as the MAC PTCY method, and the Beijing protocol, which is the GIAC protocol, which is predominantly ATG based. So here, if you can notice, there is only ATG in the Beijing protocol, which is the third one. There's only ATG and there is no PTCY. And what now we are looking for, each of these has had over years and years, we know that it's all evolving with time. And over years, because of seminars like this and because we discuss and, we meet and everything, people know that either or of one of these is not giving the best outcomes and it has associated complications. So the whole idea of, can we mix both? Can we do a little bit of ATG, a little bit of PTCY, and would that improve the outcomes? And I think India, as in India, we are poised at a very good status to give data to the world on this, because we are doing a lot of haplotransplants and we do a lot of PTCY. So adding ATG to that combination and looking at how that improves outcomes will be something that I think as a country and as a society that we can do more. So the whole idea of high-dose post-transplant PSI was proposed way back in 1960s in the John Hopkins group, where it was shown to prevent skin graft rejection when administered 2 to 4 days after allograft. There were several time points at which it was given and found to be in various ways effective. However, the most efficacy on the alloreactive T cells, that is the T cells which result in graft rejection and GVHD, was found that when you give on day +3 and 4, the effect was predominantly more than if you give it earlier or later. And the reason being is that at the 72nd hour after infusing a T replete graft, which means a graft which has not been manipulated, a graft from a half-matched donor, which is full of the T lymphocytes from the donor, if that is infused into the child, about 72 hours after that is when the maximum amount of alloreactive T cells are known to or have been found to be present in the patient. And if we hit those alloreactive stem cells correctly at the 72nd hour, the cyclophosphamide goes and targets specifically those alloreactive T cells and therefore prevents rejection as well as decreases the risk of GVHD. So there is also a sustained Treg production and homeostasis associated with the whole idea of giving PTCY, and Tregs we know are very important because is required for GVHD prevention, and HSC-derived Treg maintenance is required for chronic GVHD prevention, which is the graft-derived Tregs are also, so you cannot destroy the Tregs as well, which is why you wouldn't want to give it probably earlier than day +3 and day +4. So you need Tregs from the graft, and you need the patient also needs to produce their own Tregs eventually to have decreased risk of chronic GVHD. So that is why PTCY was found to have an effect in GVHD prophylaxis. It has several advantages. It's inexpensive, of course, does not require training and administration. It's very accessible. And it has been shown to be effective in preventing severe and chronic GVHD, selectively toxic to the proliferating alloreactive T cells. It's non-toxic to the hematopoietic stem cells because we know that the aldehyde dehydrogenase, which is required for metabolizing the cyclophosphamide, is lacking in the stem cells. So therefore, the stem cells get spared. So the 72nd hour is where the dose of 50 mg per kg per day for 2 days is given. However, in administration, when you administer cyclophosphamide, especially in pediatrics, we need to watch for the side effects. It can be highly emetogenic, so therefore need to give right CINV prophylaxis. It can be bladder toxic. We know, of course, alkylators, cyclophosphamide, ifosfamide can cause hemorrhagic cystitis, which is not uncommon. So we need to hydrate the child adequately. It can be cardiotoxic, especially when given in babies, infants. So nausea and vomiting, a few things about cyclo. This is not an absolute sort of thing that you avoid forceps always. However, You know that with ifosfamide, fosaprepitant should not be given. We know that. With cyclo, there is no absolute indication to not give fosaprepitant. However, maybe avoid giving it due to the interactions and give it after finishing the cyclophosphamide on day 4. Mesna, definitely 24-hour infusion with Psy. The dose of Mesna here we know is higher than the usual dose that we would give in our solid tumors. Here, the dose is 1.5 times the dose of the cyclophosphamide is the amount of Mesna that which needs to be given. And given as a 24-hour infusion, it works better in decreasing the risk of hemorrhagic cystitis. Post-alkaline diuresis is important. In less than 2-year-old children, we need to watch for SIADH, watch for PRESS as well, and for sodium, of course, SIADH. So infants, this is data that has been published where the CMV rates have been very high in infants when this full dose of Psy has been given, 50 in twice a day, 50 for 2 days. And what we have found, and even what has been published, is that when it was given in babies younger than 1 year of age, the cardiac toxicity was very significant with cyclophosphamide. So in our unit, in general, we avoid giving PT-Psy in those who are less than 1 year of age. And babies who are less than 1 year, we prefer the other protocol of T depletion as compared to T deplete graft for this reason. And and the other thing with because it affects the heart, as a policy in our protocol, in our unit, we do the 2D echogram in the child on day +5 to see if there is any mild cardiac dysfunction. And if there is, then in our unit, levocimendin is what our PICU colleagues have recommended. And we have paper on that, which is in the process of publication, where levocimendin has been shown to improve cardiac dysfunction in upfront, especially in this cohort of patients. Now, low-dose PT-Psy is what was investigated. There is some data on this, 25 milligram per kg instead of 50. However, there was higher chronic GVHD. So therefore, now what should we do? How do we improve outcomes with PT-Psy, decrease toxicity, but at the same time decrease chronic GVHD? And here comes the role of ATG. ATG, we know, is antithymocyte globulin. It has a polyclonal, nature. It induces B cell apoptosis, and it is very good in terms of induction of Tregs and NK and T cells. And it has been shown to decrease GVHD prophylaxis. Now we know about ATG that it is multifold effects. If you give it earlier in your conditioning, like day -9, 8, 7, it not only affects the donor, it affects the recipient T cells as well, which means it can decrease the risk of graft rejection. And if you give it closer towards the infusion of stem cells, it acts predominantly on the recipient as well as the donor T cells, and therefore can prevent GVHD as well. So where we give, of course, we have to still have some more data on which is the best timing for ATG, but that is where we stand. And a combination has been shown to be synergistic because infusion of ATG can deplete the early active T lymphocytes, and administration of PT-Psy can eradicate rapidly proliferating T cells. So here, especially in the haplo protocol, probably ATG may be more effective given earlier instead of more closer to the infusion, because anyway, we're going to give PT-Psy afterwards. So there is, again, several publications on where the two have been combined. Some data coming from this group where they have combined in haplotransplants a lower dose combination, so not the full dose of ATG along with PT-Psy. Again, similar data coming in unrelated donors as well, where low dose PT-Psy was combined with. So they're giving up to 1 to 2 milligram per kg of ATG every day for 3 days. Again, similar data coming from another group from China, where if you can see the outcomes and the overall survival, everything was much better in those who non-relapse mortality. Everything was significantly better in those who received ATG plus PTCY combination. Now, at our center, we we use the combination in several conditions, but I'd just like to discuss 2, which are non-malignant conditions, where we do haplo-PTCY. One is, of course, Fanconi anemia. So this was an earlier paper which we had published in Blood and Marrow Transplantation in the Journal of Transplantation and Cellular Therapy, JTCT, where we had used fludarabine cyclophosphamide 2-day TBI with PT-Psy in Fanconi anemia. And we had significant rates of acute GVHD and chronic GVHD. Rejection rates were about 10%. And the reviewers had actually written back to us saying that, we are publishing your paper, but please look at your data and look at your protocol, because the GVHD for a benign condition should not be so high. So we did look at the protocol, and then because there is data published, from Bonfin et al. And several other groups, EBMT and all, where ATG can be used in this particular condition, we did do the next protocol with ATG, where rabbit ATG was used on day -4, 3, and 2. And this has also been published recently this year in Blood and Cell Therapy, and on comparing the two cohorts, there was a significantly improved or significantly decreased risk of acute GVHD from 73% to 7% in children with Fanconi anemia when we added serotherapy with ATG in the same protocol. And overall survival increased from 64 to 70% in this group. There wasn't any difference in the rejection rates or the graft failure rates. It was similar, irrespective of whether we added ATG or not. Another place where this combination of ATG with PTCy is used is in THALS. This is another thing that we have published about augmented immunosuppression with PTCy. And earlier we had 95% overall survival. However, rejection was significant in this cohort. Therefore, subsequently, we have modified the protocol for Thiotepa Cy-Flu RATG TBI, single grade TBI, to Thiotepa Trio Flu RATG 2-grade TBI. And we found that rejection rates were significantly less, almost 13% to 4%. Infections were almost similar, viral reactivation almost similar, but what in the second cohort we found very high was the rates of late sinusoidal obstruction syndrome and the rates of immune cytopenia. So therefore, in this protocol, now we are regularly adding the use of IVIG for the first 3 to 4 months post-transplant in the second cohort, so that that has helped us in decreasing the rates of immune cytopenia. Of course, everything comes with a price. It's not foolproof. PTCy by itself is immunosuppressive, so therefore there is an increased risk of viral reactivation. ATG is also immunosuppressive, and we know there is an increased risk of viral reactivation. And here we are combining. So the immune reconstitution can be severely delayed, and the viral reactivation rates can be high in this combination, which really needs to be monitored. So therefore, in the future, if there is a trial or something that possibly we need to look at, is keeping the low dose ATG and keeping low dose PTCy instead of 50 per kg, if we can decrease it to less than that, which may therefore help in improving immune reconstitution and thereby decreasing CMV reactivation or adenoviral reactivation rates, is something that needs to be worked out in the future. Thank you. And I'd like to thank my wonderful team, my mentor, Dr. Revati, and Dr. Anurag, and my colleagues. Thank you for the attention. And thank you for the opportunities.
Thank you, ma'am, for that wonderful talk. And now we head on for the panel discussion. And for that, we have Dr. Ruchira Mishra as our moderator.
I'm going. Can you see my screen?
Yes, please go ahead.
Yeah, perfect. So I'm just
Can
going to
you
put
make
that
it on full
on
screen? Yeah, full screen.
slideshow. Yeah.
Perfect, ma'am. Please go ahead.
Yeah. So thank you, Ramya. That was an excellent overview of PTCy and ATG. In fact, it brought out the nuances of why we use these two drugs in haploidentical transplant. So that was really good. I have two disclaimers, and one is that the session is sponsored by Sanofi, and where we will be discussing the holy trinity of engraftment, immune reconstitution, and GVHD, ATG and PTCy in haploidentical transplants. I have a very good panel with me, experts from all over India. That's Dr. Ramya is already here. You've heard her already. I also have with me Dr. Uday Kulkarni, who's a professor in the Department of Haematology at Christian Medical College, Vellore, a very well-renowned hematologist, and Dr. Kanan Subramaniam, who's also a hematologist at Sahyadri Specialty Hospital and KM Hospital at Pune. So welcome, everyone. Again, this disclaimer is meant for physicians only and is meant to be a discussion only. However, we request you to please read more before you make any judgments. So what we want to discuss today is one, the magnitude of GVHD burden in haploidentical transplants that we see across the board, whether there are any evidences for the role of PTCY, and Ramya has already gone through that a bit, as well as look at evidences for the role of ATG, and whether we can combine the two and prove to be beneficial for patients in general, or whether there are some disadvantages to the two, combining the two methods as well. So my first question would be to Dr. Subramaniam. What type of haploidentical transplants do you actually prefer to do for malignant diseases? Knowing that we know that there are two main types of haploidentical transplants, both T-cell replete and T-cell deplete. So is there a preference when you're dealing with malignant disorders and with non-malignant conditions, or you would offer either of the two to any patient?
Okay. So I would actually prefer to do the PTCY transplants to malignant, and prefer the alpha beta to the non-malignant. But it's also true that I've not done too many alpha beta depletion to really comment, because I do hear from my colleagues that you could do the alpha beta depletion in the malignant diseases also.
Dr. Kulkarni, do you have the same choice, or is it different?
I think he's not joined, Dr. Kulkarni,
Okay.
from what I can see.
So Ramya, what do you do?
So that's for malignant disorders, certainly only the PTCy approach is what we have used. For non-malignant, depends on the condition. PTCy for, as I mentioned, for thalassemia and for Fanconi anemia, and aplastic anemia as well. In the immune deficiency group is where the main debate comes: should you do PTCy versus TCR alpha beta? And especially in the immune deficiency, because they're all baby, most of them, not all, but some of them at least, predominantly they are babies less than 1 year of age. In that case, certainly only TCR alpha beta. And also, if they have come with a lot of comorbidities, they've come with a lot of infections in the immune deficiency, even the older children, and where we suspect we need to give some amount of myeloablation without making it too myeloablative, and at the same time give higher doses of stem cells so that we prevent graft rejection. And those also, like TCR alpha beta, is what we would prefer.
Yeah. So my personal preference was the same, that for malignant disorders, to give the GVL effect, would prefer to use a PTCy regimen, and for the non-malignant conditions, provided it is cost affordable for the patient, would try and do a TCR alpha beta depleted transplant. However, we have, as Dr. Karan mentioned, other colleagues who are very comfortable doing TCR alpha beta depleted transplants for malignant conditions as well. So the first question is, do you find differences in immune reconstitution between the use of ATG and PTCY when you're doing a transplant? Have you ever compared the two in your cohorts? Dr. Kanan?
Yeah, no, we still haven't done a comparison of the immune reconstitution between the ATG and PTCY. For us, like what Ramya has mentioned, right now we are in the process of sort of combining these two together, because initially it was just PTCY, and then they got added. But what we have recently done is actually reduce the dose of PTCY and added the ATG. But for most of our other patients, we are actually doing the ATG away from the transfusion, not near the stem cell infusion. I think for our cohort, we have still not analyzed. But compared to a previous cohort where we were using only PTCY at a higher dose, I think this has given us much better in terms of the kind of infections that we are seeing, and of course, early engraftment. So previously with only PTCY, single agent, higher doses or the standard doses of 50 milligram per kg, it was in the range of 17, 18 days. Whereas now with a combination of ATG and PTCY, we have been able to come down to say 12 to 13 days is our usual sort of experience that we are seeing. But we have still not analyzed in detail as to what kind of numbers of T cell. We don't have the data. We are collecting that. We should be analyzing that. But I'm sure that will be better.
Dr. Kulkarni, thank
There-
you for joining in. Do you have seen any difference in the immune reconstitution when you use ATG with PTCY or when you used PTCY alone?
So with PTCY, we have a study which is ongoing wherein we are looking at the immune reconstitution. ATG, again, we don't have much data from our, in the setting of transplant, we don't have data on the immune reconstitution, but what is published in an EBMT, registry data recently, there are differences in the immune reconstitution where vis-a-vis the gamma delta and the NK cells coming up earlier with ATG and those being delayed with the PTCY. So there are nuances to it. Of course, the infection spectrum is also different, wherein you see more of bacterial infections with the PTCY platform. With ATG, you might have, I mean, of course, CMV also we see, but with ATG specifically, EBV and the other viral infections is what we monitor for. So yeah, those are the broad differences in the immune reconstitution pattern. Yeah.
Okay. So I managed to look at this review that looked at ATG and post-transplant cyclophosphamide for GVHD prophylaxis in peripheral blood stem cell transplants. And what they did find was that their viral reactivations were much higher in the ATG arm. So that was clinically significant, especially at day 100. That was very, very significant. And there was really no difference in terms of relapse incidence or overall survival in these patients. Or even with GVHD, the results were not very different. Though when you look at the percentages, the PTCY arm definitely had lower GVHD, especially chronic GVHD, as compared to the ATG arm. And especially engraftment, as Sir mentioned, was faster when you're using the ATG arm as compared to using PTCY. So, Ramya, the next question to you is, what is the incidence of acute GVHD that you see with haploidentical transplants at your institution and also chronic GVHD? Are you really worried about them when you're using these protocols?
Certainly not with the PTCY, ma'am. Somehow with PTCY haplo, the GVHD rates have been extremely less, whichever condition it is that we are doing. Fanconi, we had almost acute GVHD of 73% in the previous cohort, where we did not add ATG. However, most of it was, grade 1 to 2 or 3 GVHD, which resolved. Of course, with the addition of ATG, the GVHD rates came down in that group. But I think we need to look at diseases per se, because Fanconi, those kids were all those who were multiply transfused, with a lot of allo antibodies. So that it by itself predisposes them to GVHD. But per se, as a protocol, the PTCY, the GVHD rates are extremely less. But what we are worried about is the viral reactivation. Almost everyone has that.
And Dr. Talan, since you do more of adult transplants, do you see more acute or chronic GVHD as compared to your other kind of matched siblings and matched unrelated donor transplants? Or are you comfortable offering a haplotransplant and not really worrying about GVHD in your cohort? I can't see Dr. Kannan.
Yeah. We have not yet done for thalassemia. We're still not offering haploidentical transplant at our center. We are doing only for diseases, and we are not yet doing it for haploidentical transplants for thalassemia. We have not done.
But when you do a haplotransplant as compared to a matched sibling or a mud transplant, do you see more GVHD, or do you think the incidence is almost the same?
No. With PTCY, we have had actually we have also done few of mass sibling transplant with PTCY also, the PTCY. But in maybe around half of them, we do end up seeing GVHD, even with a mass sibling, followed by PTCY. But it was not grade 4, and it would get easily controlled with the standard GVH medicines that we would do. But overall, it's much better than um, in PTCY compared to not giving a PTCY.
Yeah. So we definitely know that GVHD is a very formidable barrier to successful allogenic transplants, and the bigger the mismatch, the higher the risk of GVHD. However, since we're using ATG and we're using PTCY, this incidence is actually much lesser. So now the incidence is for chronic GVHD has decreased to just about 30%, whereas previously it was much higher in the cohort. So definitely helping us more. So my next question to you, Dr. Kulkarni, is what kind of so Ramya, could I ask you this question, because this is more for non-malignant disorders, and in pediatrics we tend to do non-malignant first more. So what conditioning regimens do you generally choose for your T-cell replete transplants? So like for a Fanconi's, would you offer them cyclophosphamide both pre and post?
So so I think depending on the condition and how much of immunosuppression and how much of myeloablation is required is what decides the conditioning. For example, for THALs, we certainly need myeloablation. The conditioning that we had done without triosulfan thiotepa with only flu-cy 2-grade TBI with rabbit ATG, which was predominantly immunosuppressive, resulted in rejection rates were almost 25% in that. Although nobody died, touch wood, but the rejection rates were 25%. However, when we made the protocol more myeloablative with flu trio thiotepa and rabbit ATG and the 2-grade TBI, rejection rates have been just about 4% or even less. So in that condition, you would require sickle cell, probably the same. Fanconi anemia and aplastic anemia, certainly we would give a very reduced toxicity conditioning or even reduced intensity. The cyclophosphamide is used pre and post transplant, but the post transplant Psi in Fanconi is only 25 mg per kg, we know, because it's a DNA repair breakage defect. And the pre transplant Psi as well is the reduced dose of 5 mg per kg for 2 days in Fanconi. With severe aplastic anemia, the pre transplant Psi is usually the 14.5 for 2 days, and post transplant would be 50 per kg in those.
Do you think that this results in more GVHD if you're using a lower post-Psi regimen?
Not in, so that's why in the Fanconi's probably the GVHD was so high in the previous cohort, but since we've added ATG to the same combination of decreased Psi pre and post, the ATG has helped in getting over the GVHD rates, certainly.
Dr. Uday, the next question to you is, what do you think would be the conditioning regimens that you would choose for a haplo T-cell replete transplant for malignant disorders?
Yeah. So I think for the ALL subgroup, what we do is we give total marrow lymphoid irradiation, TMLI based protocol with Psi. And because we are coming in with PTCY in the replete platform, we give the Psi before. So they get Psi first, then they get the total marrow lymphoid irradiation, so that the post Psi and the pre Psi shouldn't come too close.
Okay.
So we ship the Psi before. So that's what we do for ALL. For AML, we are using standard flu-mel TBI. Or if they have high risk features, or if you're doing a AML CR2, we would use flu-bu TBI. But we do targeting of busulfan. We do a targeted bu at our center. In patients who are elderly, we prefer trio. So we would give flu trio and flu trio TBI for patients with AML or MDS in the elderly. So those are the broad regimens that we use. For deplete, we use similar regimens. There's no, I mean, we haven't done deplete for ALLs so far. We have done for myeloid malignancies. We have done for elderly AML as well as for patients with MDS and few children with immunodeficiencies. So broadly, yeah, I think the similar protocols that we use, we don't change the conditioning much, but one point I would like to add in the previous one, as I agree with Dr. Ramya, that when we add the ATG, especially for aplastics, it's a standard ATG away from the graft would improve the engraftment. So, if you have, the other thing that is important is increasing the TBI dose to 400 centigrade there on day -1. That's also another thing that is shown to improve the engraftment. So those are the broad thoughts on this. Yeah.
Dr. Kannan, any difference of opinion?
Not difference in opinion, but yes, for the ALLs, we have done not TMLI, we don't have that. So we would do TBI with flu, followed by, and when we are doing haplo, right now, all our protocols are with ATG and the PTCY. And for the AMLs, because we don't have targeted busulfan, we have shifted to flu trio.
Yeah.
Most of them flu trio and some of them flu mel. So that is what we are doing for the conditioning, in terms of conditioning.
I know
But-
CMC Vellore is blessed to have the busulfan pharmacokinetics. Till very recently, it was probably the only center doing busulfan pharmacokinetics, but I believe NH Bangalore has now started doing it as well. So you've been blessed with that. And also TMLI is very, very restricted to few centers. So in pediatrics, we generally would be doing either TBI ETO followed by PTCY because that's how we want to change the alkylators. Or we were doing TBI flu and we've got good results there for a T-cell replete transplant. And I agree that we really don't change our regimen whether we're doing a T-cell deplete or a T-cell replete transplant for our patients. So, Dr. Uday, what do you think would be the advantages of using PTCY?
Over and above, which as
or
compared
just the advantages, why would you prefer PTCY in a haplotransplant?
Yeah, so I think of course, the cost is one thing, the deplete is hugely costly. So I think that's the primary advantage of PTCY. The other advantage is that, especially with in other indications, like in 9/10 mud, where the GVHD rates would really come down, extensive chronic GVHD rates would really come down with PTCY. So those are the two broad advantages, I think. If you're doing a mismatched unrelated, like a 9/10 mud, that's where definitely would like to use PTCY. And also, when we are doing a haplo where cost is a concern.
Yeah. So yes, Ramya did talk about this, and she did mention that slides not moving. I don't know why my slides are not moving. So she spoke about this, that one, it is the benefit of having an inexpensive treatment, which is why most people like to prefer using PTCY. It does not require any intensive treatment. It's very, very accessible and has definitely shown clinical outcomes have been better with use that both acute and chronic GVHD are prevented, toxic to the hematopoietic stem cells. We have enough data about that. So there are a number of studies that have shown that PTCY is better on using these as pediatric populations, which have shown the benefit of PTCY by decreasing the incidence of GVHD. Then, Dr. Kannan, what do you think would be the disadvantages of PTCY?
Okay, the disadvantage was, one is actually the delay in engraftment that it does cause. There is an increased risk of CMV infections when we use that. And like Dr. Uday mentioned, also higher risk of bacterial infection on our cohort, especially in India, we being rich in all kinds of bacteria. So broadly speaking, these would be the disadvantages. And even if you look at data, I think we still do not understand which is the best regimen. So you have 50-50 on day 3, 4. There are some regimens which use day 3 and 5. And then, of course, there are lower dose regimens, some people using 40-30. I even found a regimen where they give 50 on the first day and 25 on the second day. So I think as a group, we do understand it is a fantastic drug because that is what made haplotransplants possible as of now. But I think some fine tuning, tweaking of the dosages and the days, I think that obviously we will learn as the time goes.
Yeah, I completely agree with you that there is lots of data out there. When you start reviewing papers there, you find all sorts of doses there. What generally is mentioned is that there is delayed immune reconstitution, which leads to higher infections that we have spoken about, especially with CMV. And some papers say that it's as high as 83% in their cohorts. There is, of course, the risk of donor-derived leukemias with alkylating stem cells being used, with the agents being used, and all because cyclophosphamide is associated with an increased risk of secondary malignancies. And you mentioned bacterial infections as well, and I completely agree that we do see more infections. So Ramya, do you think ATG would really help in preventing GVHD in these patients?
Yes, I mean, depending on the dose and where we add it. So we used to add ATG in all our patients on day -4, 3, and 2. And then we attended this talk by Yap Collins when he came to India and he went from place to place to place to place talking. And after that, completely we have changed our thing. So whether now this is good or that is good, we'll only have to see with time once we look at our data pre and post Yap Collins. Actually, truly, honestly, that one day we attended one talk by him and then that's it. And we changed as completely to day -9, 8, and 7.
Yes, so now we
I mean,
become pre-Yabolans and post-Yabolans.
Absolutely. I just completely that one day. And then now we'll have to look at whether this is truly helping or not. But what we are doing is that now we, especially in the THAL patients, we are looking at CD4 at day 30 and day 60 and seeing if it is going above 50 or what has been their immune reconstitution. We haven't looked at that yet. Only now we are looking at the numbers. And certainly, I mean, GVHD, I mean, the Fanconi cohort itself, we have published that the ATG made a huge difference, statistically significant difference from 73% to 7%. Even the chronic GVHD rate went from some 36 odd to 10%. So it certainly helped. And yes, I mean, but the immune reconstitution and viral infection rate is something I think only with time we will know once we look at these patients who are surviving.
So you did mention this in your presentation as well, that there are multiple points of action of ATG, and that's how it actually works in preventing GVHD from occurring. And therefore, that's something that has been proven by multiple trials. Especially, there are 3 trials that I've put in, which are the Gitmo trial, which was started in almost about 2006. Followed by the Finke trial, the German trial in 2016, which have all shown that there is a significant reduction when you use ATG with PTCY in these. And therefore, the meta-analysis also kind of goes in favor of this. So the next question then came in was, should we be doing either PTCY or should we be doing ATG? Because this was something that we were discussing, that since both of them seem to be acting on the T cells, do you think it's actually beneficial or should we be using one versus the other? Dr. Kanan, what do you think?
I think it would be the combination, not one or other. I think that's what would make a difference in terms of probably the haploidentical transplant. But we should understand, like what Ramya said, when should we give and how much should we give? No, even that ATG, still we don't have a complete answer. And I think even there is data now to say whether it should be one dose, single dose based strategy, or it should be more based on the
Yeah.
ALC levels and then decide. More so in the children because of the huge range of lymphocytes. Adults, it might be much more stable, but we do see people with more and less number of lymphocytes. So this, I think now, again, newer data emerging as to adjust your ATG doses based on the ALC, and that uh, has shown some results in terms of the recovery of immune function. I think there's one paper there for that, right? The Miral and group.
So that do you actually change your ATG dose based on the ALC, the absolute lymphocyte
No,
count?
still have, but I'm
Yeah.
saying, but that seems a logical step in trying to adjust the ATG because
Ramya,
it might.
doses on ALC?
Sorry.
Ramya, do you base your
No,
doses on
no,
ALC?
no, 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 not at the moment. No.
But I think
We
the Bangalore.
tried, yeah. No, we tried to look at that nomogram. Honestly, we did, but it was very confusing, and we couldn't understand what we are supposed to do with that information. So, I mean, no, I don't know at the moment. No.
So, so there have been trials which have compared looking at either ATG or even just PTCY. And like Ramya mentioned, that when they were initially using just PTCY, they had a different result as compared to when they started using ATG with the PTCY in the Frankenese group. So all of them, there are papers to say the same thing, that ATG would have give you better engraftment, it would give you a better progression-free survival or overall survival and lower non-mortality rates. But it also, we found that with PTCY, it is often better in terms of your viral reactivations. So, as Dr. Kannan mentioned, we can now look at both of these. You can look at trying to infuse both using the two combination regimens. And the synergistic action would then happen because your infusion of ATG depletes the early active T lymphocytes, whereas PTCY only eradicates the rapidly proliferating T cells. So therefore, it has a synergistic effect in these patients. And again, clinical outcomes of the two have shown that this has proven to reduce both acute as well as chronic GVHD incidence in these patients as well. Again, a number of trials that have been done and looking at overall survival, looking at acute GVHD, chronic GVHD, and they have found that using a combination actually works better than using either of the two all alone. So one of the key used initially was the Bain protocol, which was using GCSF and the ATG regimen, better engraftment and decreased rejection in these. But the PTCY regimen actually is much better, and a combination of the two definitely works. So my last two questions for the day. One would be the role of ATG post-engraftment to decrease the incidence of chronic GVHD. All this time we've been talking about using ATG pre-transplant. Do you think there's a role to use it post-transplant? Dr. Uday or Dr. Kannan?
I think, no, I mean, I'm not aware of any data in post-engraftment to reduce the incidence of chronic GVHD. Like using ATG post-engraftment, I am not aware of. In the important place where I think ATG is useful would be in say aplastic anemia, wherein I would definitely use it away from the graft along with PTCY. So that's something for sure. I think that's where we would definitely use both together. I'm not sure about post engraftment, and will the two come? Yeah, no clue about that.
So combining the two, we've already discussed this, that combining the two definitely works. And in some places, we have evidence now to show that we can decrease the dose of the cyclophosphamide later on, especially in diseases like Frankenese, where we were initially using a lower dose and having chronic GVHD coming in. Now with the addition of ATG, we are seeing that those GVHD rates are decreasing. Dr. Karan, any thought about using ATG post engraftment?
Okay, I think not recently, but we have been we were thinking of using ATG post engraftment only in scenarios that was pre-Jakavi era, when we used to have very severe GVHD not getting controlled, not responding to anything. Then we have been wanting to use ATG, but did not have the enough thing to use ATG at that time. But I don't think in the present era, post engraftment, theoretically, probably that will be the only situation. But I think at this point of time, Jakavi and newer GVH treatment being available, I don't think there will be a role for using post engraftment per se.
Yeah. So some of our younger colleagues would not have ever used it. I mean, we've used ATG as part of steroid refractory ATG treatment as well. But while I was doing this review, there is a paper which has just been published in March 2024. And you can access it on bone marrow transplant, which is coming from a Chinese study where they have used PTCY post-engraftment with ATG. Again, post-engraftment ATG, and they have found that has reduced their moderate to severe chronic GVHD from both HLA-matched unrelated as well as in haploidentical donor transplants. And so that's something that they found was very good because their rates have dropped considerably in this cohort that they have used it. There. Recent study still very cautious, but especially thinking about the kind of lymphodepletion and viral reactivations that we would have to worry about in these patients. And as Ramya already mentioned, so low dose post-cyclophosphamide with ATG, decreasing the dose of post-transplant cyclophosphamide has also worked very well with Fanconi's and with adult severe aplastic anemia patients as well. So again, another study from China published last year in May 2023 shows that this is a very good regimen to kind of follow. But again, as I said, the rates of CMV reactivation were pretty high in this cohort. So using the combination still made you worry about viral reaction. So both EBV and as well as CMV, their CMV rates were 82.4%, and their EBV reactivations were around 18% in this cohort. However, they had no graft failures, they had no deaths in this cohort, and they found that this was doing very well, and all the GVHD was just about grade 2 or grade 1, not severe GVHD at all. So worked very well for them at lower doses. So thank you everyone for this. We end our presentation. Thank you, Dr. Kanan. Thank you, Dr. Uday and Dr. Ramya for being the faculty for today. This has really helped us all, and I hope that this discussion has been fruitful for everyone. If there are any other discussions or any other questions from the audience, our panelists, I'm sure, would be more than happy to answer them. We can take them up.
So there are two questions, madam, from Dr. Nishad Dakate. The first question from him is, any role of dose of CD34 stem cells in the graft on GVHD and engraftment? Any impact of dose?
So Dr. Kanan, do you want to answer that? CD34 cell dose on engraftment and GVHD.
Okay. See, if I think those kind of questions can be answered more in, say, the depleted transplants, where we do the alpha beta depletion and where we are able to target the higher doses of CD34, because beyond certain level, an increase in CD34 will also lead to increase in lymphocytes. Increase in CD34 in a non-manipulated graft will actually lead to increase in the amount of T cells present, and that can actually impact your GVH acute chronic both. But whatever initial studies they were done, you couldn't really decrease the T cell in a non-unmanipulated graft to a level where it could really impact the GVH scores. There should be some correlation between the numbers, but we know that the minimum numbers, those are required for transplant is in the range of, say, around 3 or 2. Autologous may 2 and allogenic may 3. So beyond these broad, this one I'm not too sure. But in haploidentical transplants, we are targeting in, say, unmanipulated somewhere between 5 and 7 is the usual target we are using. We are not going higher than that.
So what we would generally do is keep a cutoff of 8 CD34 cells, but we're also looking at the CD3 positive cells, and we're keeping those to a minimum as much as possible. So we try not to go beyond 2 into 10 to the power of 8 for that. So the CD3 actually determines our risk of GVHD is what we feel. For haplodeplete transplant, so the TCR alpha beta 20 to 25 million per kg of CD34 positive cells, because we know that they have almost negligible T cells. Ramya, any difference?
No, I think pretty much the same, but we just looked at our haplo PTCY patients and those who had rejected the grafts, and we did some ROC curve thing with the statistician, etc. In about 90 patients we had analyzed the data, and we found that CD3, when it was less than a minimum of 1.5 into 10 to the power 8, the rejection rates were much higher as compared to those who had a higher CD3 in the graft. And GVHD per se did not make a very big difference, even though the CD3 levels were high, especially I think because we are doing the PTCY protocol. So in our unmanipulated T cell replete grafts, we actually are looking more at CD3 as compared to CD34. So we are maintaining a CD3 of at least 2 into 10 to the power 8. The corresponding CD34 sometimes comes to even 8, 9, 10 times as well, but we are not going down on the CD3 because since we have done that, our graft rejection rates in general have been less.
That's interesting. Yeah, that is, yeah, that.
Thank you, Dr. Ramya, for bringing that out for the CD3 dose actually. Another question from Dr. Nishad Dakate. Any role of predixafor in stem cell mobilization by collection in allogeneic stem cell transplant?
Yep. So prelixafor we've used quite commonly when we're doing autologous transplants, especially in pediatrics and for neuropaths. We've used prelixafor very, very regularly. We find that it gives you a very good CD34 cell count, especially in the poor mobilizers who haven't worked well with GCSF alone. There is a study that has come in. I think Dr. Yadav published it, where he's used prelixafor for donors, normal donors as well, and found that it gave a good count. I don't think they've done any comparisons on looking at GVHD rates or engraftment or anything else with that. And I'm happy to be corrected if somebody has read up something about it otherwise. So it gives you a very good CD34 count. I've not known any patient to fail plerixafor. But we don't know whether that really increases your GVHD risk or not.
True, ma'am. So there are no other questions from the audience. Any other discussion want to ask any other question or want to comment or advise anything? Fine. So, well, so we are not on time. Should we move out to our next session? Dr. Uday Yanamundra has already joined, or you want to discuss? We've got still more time, 5 more minutes.
No, that's it. Thank you for the opportunity.
My question only will be, what is the kind of ATG that we are using? The Grapholon or the Rabbit?
We generally preferring Rabbit ATG. We've used Grapholon initially as well, but when you look at the cost, Rabbit ATG kind of scores up on costs. And again, Dr. Gaurav Kharga's team did a kind of an audit of their Grapholon versus Rabbit ATG patients. And they found that the risk of thrombocytopenia was far higher than in the Grapholon arm versus the ATG. The ATG definitely, the Rabbit ATG caused more immunosuppression and therefore more viral reactivations. So I think Gaurav has presented that paper as well. So he's published that. So that's there. But both work very well. The doses are very different. So people should not use the same dose.
And what kind of ATG?
Grapholon has a higher dose.
And what is the dose of ATG that you're using, ma'am, for the rabbit ATG
So-
in
Yeah, rabbit ATG, we're generally using between 5 and 7.5 milligrams, so 2.5 milligrams on each day, or 1 to 2.5, like that. Graflon, their initial studies were about 30 milligrams per kg total dose. Yeah, but now they're again also coming in with lower doses, where they've used as low as 15 milligrams per kg total dose also. And that seems to have worked.
Okay. Thank you.
Thank you, Dr. Kannan. And thank you, Dr. Ruchira Mishra, for handling very well. You moderated the session. Wonderful and fantastic it was. Thank you so much, ma'am. And now we move on to our next session. Let me share the screen again. So after this beautiful session, our next session is sponsored by Jensen. And we have our guest speaker, Colonel Dr. Uday Yanamundra from Pune. And he doesn't require any introduction. He is very well-known entity. So Colonel Dr. Uday Yanamundra is MD, DMSS, DNB, MNMS, DM Clinical Hematology, Professor Medicine and Hematology at Armed Force Medical College, Pune. His academic qualifications include MBBS President Gold, MD Gold Medalist, DNB National Gold Medalist, DM Clinical Hematology, DMSS, MNAMS, and FICP. His academic achievements are Colonel S.N. Prabhakar Gold Medal, Brigadier I.P. Bhala Gold Medal, Chief of Army Staff Medal, late Shri Sudhir Singhal Gold Medal, Sam G.P. Moses Gold Medal, Rashi Memorial Medal. He was also the Pune University rank holder in the subjects of forensic medicine, microbiology, and ophthalmology. He has about 175 publications with 90 PubMed indexed, H index of 12, and RG score of 37.35. His research awards include: he's a Chief of Naval Staff Award. He received the Chief of Naval Staff Award of FMRC in the year 2022. He was also awarded FICP in the year 2021. He also received International Young Investigator Award in High Altitude Medicine at Italy, Bolzano in the year 2014. He's also received the Ash Scholars at San Francisco, USA 2014 and Brisbane, Australia 2016. He also received International Development and Education Award at ASCO, Chicago, USA 2016. And also he received the Dr. D.P. Basu Young Cardiology Award at API in the year 2018. His research awards include E. Merck Award API 2019, Best NBE Young Achiever Award ANBAI 2021, Dr. J.C. Patel Best Paper Award MHG 2021, Best Oral Paper Award ISBMT, as well as Korea 2021, Indian Myeloma Congress Mumbai 2019, International Cancer Congress Delhi 2017, and Hematocon Hyderabad 2014. He has also been the examiner for MD Medicine, DNB Medicine, and Doctorate of Medicine, Doctorate of Hematology, National Board. And today is with us and is going to lecture us on primary refractory and extramedullary disease. Is there light at the end of the tunnel? Let me introduce our discussions for the day. And here is in alphabetical order. To start with, we have Dr. Akanksha Chaudhary from AIIMS Bhopal, Sergeant Commander Dr. Arun VA from INHS Aswini Kolaba, Mumbai, Dr. Ashish Dixit from Manipal Hospital, Bengaluru, Dr. Deepak Charles from Aster MedCity, Kochi, Dr. Krishna Prasad from Bangalore Institute of Oncology, Bengaluru, Dr. Madhupriya Borappa from State St. John's Hospital, Bengaluru, Dr. Mallikarjun Kalashetty from Comprehensive Cancer Center, Manipal Hospital, Bengaluru, Dr. Manoj Uni from Amrita Institute of Medical Sciences, Kochi, Dr. Monica Chennareddy from Vaidehi Hospital and Research Center, Bengaluru, Dr. Nikhil Krishna Haridas from Amrita Institute of Medical Sciences, Kochi, Dr. Prashanta Bhatt from KMC Hospital, Bengaluru, Dr. Ruchi Khanna from Kasturba Medical College, Manipal, Dr. Satish Kumar A from Columbia Asia Referral Hospital, Yaswantpur, Bengaluru. Dr. Tejaswini Gudibande from Karnataka, Max Super Specialty Hospital. Dr. Thomas Kuncheria from Medical Trust Hospital, Kochi. And these are our discussions for the day. And I thank you very much for joining over here. I stop sharing here. Over to you, Dr. Uday Yanamudra, for your lecture.
Thank you, Dr. Amit. Dr. Amit has been a very good friend of mine, and thanks a lot for those humbling words. But yeah, so the first part of your introduction was the ye hai, wo hai, and then the second part you flashed so many discussants, so you scared me out now. So let me share my slides. Can I have the permission to share my slides?
Yeah, please go ahead. Can you please on your video if it is okay for you?
Yeah, sure.
Perfect.
Okay.
Please go ahead.
So are you able to see my slides?
Yes, please go ahead.
So today we will be discussing about primary refractory and extramedullary disease. Is there a light at the end of the tunnel? So that is the topic which has been assigned to me. So quickly moving on to the topic. So we will be covering our topic in 4 different parts today. Primarily the first 3 parts about relapsed refractory, second about extramedullary disease in the form of plasmacytomas, and third about plasma cell leukemia. So coming to the first part, we all understand that myeloma has traditionally been labeled as an incurable disease, though treatable. But we all understand at some stage, the disease definitely comes back, relapses, and over a period of time, it becomes refractory, and finally patient or the individual succumbs to the incurable disease. Now, incurable isn't terminal, and I would say the whole efforts on today's date in the field of myeloma has been to convert this incurable disease into curable disease. Traditionally, the frontline therapy, people used to have a survival of somewhere close to around 50 months, and post-relapse, it comes down to 14 to 16 months, and after the patient has been labeled as refractory, the survival comes down to less than a year. Now, this was what was previously a decade back, and wherein we used to conventionally convey these graphs that with every relapse, the plateau keeps increasing, the baseline plateau, and at certain stage, the patient doesn't come back to the baseline or to the normal stage. So this was the frontline therapy, wherein this is the part on the left-hand side where you could see that wherein the active myeloma has been treated and the individual almost returns back to the same remission level. As he gets becoming relapsed, this baseline keeps rising, and this is the place where he becomes refractory. Now, the first take-home message is whenever we say a relapsed myeloma or a relapsed refractory myeloma, the baseline concept, irrespective of the advances in the medicine, is that they fare poorly when compared to the frontline therapy, despite of the aggressive therapy. Now, in no circumstances, because of the biology involved, we can bring them back to the prognostication or to the survival chances as an individual has it at the baseline. So it keeps progressing, and the prognosis keeps worsening with every passing day. Now, people have been using the word relapse myeloma and relapse refractory myeloma interchangeably, but there are some subtle differences which everybody need to understand. When we say relapse myeloma, we are talking about a recurrence of the disease after a prior response. So an individual has a response based on either the objective laboratory criteria or the radiological criteria, and a recurrence at this stage is relapse. Whereas when we say refractory myeloma, we talk about non-responsive myelomas or progression while on therapy or within 60 days of the last treatment in patients who had achieved at least a minimal response or better on prior therapy. So there is a subtle difference between the two. And for exact details, people can refer to this IMWG defining criteria for various remissions and responses, wherein they have elaborately explained about relapse and refractory conditions. Now, also people talk about the word progression and relapse interchangeably, but again, they are not the same. So when we say progression practically means a 25% increase from the last confirmed response. So if a patient has got an absolute value rise of M protein more than 0.5, you have got various absolute values. Broadly, it is 25% of the last confirmed response. And when we talk about the PET lesions, it's more than 50% rise when compared to the previous PET lesion. And when we talk of the circulating plasma cells, it is again 50% than that of the previous. So this is how we label a person having progression. So any one of these criteria, when met, would be labeled as progression. When we talk about relapse, we talk about having one of the, when we talk about particularly clinical relapse, we talk about individual having one of the CRAP criteria. Other than the CRAP criteria, hyperviscosity features, a definite increase in size of the existing plasmacytoma, or a development of a new soft tissue plasmacytoma will be labeled as an individual having clinical relapse. The second take-home message is progression is not equivalent to relapse. Relapse is not equivalent to refractory. So these are different terms, but we might use few of these terms for defining each other. And when we interpret the progression and relapses from various clinical trials, people need to understand that the authors define progression variably. They define the progression-free survival thus variably. And when we start applying the clinical trial data onto the bedside data, we should be slightly careful and read in between the lines to understand what the authors have tried to define there and what we are defining on the bedside. So when we define on the bedside, it's most of the time, it is a clinical relapse that we talk about. We very rarely, which we are going to discuss in the next few slides, are talking about biochemical relapses for bedside benefit. So people need to understand the randomized control trial data cannot be as it is applied to the real world data. It needs to be done with some amount of judiciousness. Now, coming to the indications of therapy, once we have understood what does relapse mean and what does refractory mean, so the next question comes in that what are the indications for the therapy? So when we talk of indications of therapy in relapsed refractory myeloma, a rapid rise in paraprotein, that is doubling of M protein over 2 to 3 months, or an absolute increase of M protein more than 1 gram per deciliter of serum, or if we are talking about increase in urinary protein. So these are the ones that we talk about when we say a rapid rise. But please understand, a single measurement should never be taken for making therapeutic decisions or for changing the therapy. So across the world, the guidelines talk about confirming by 2 consecutive measurements, at least separated by 2 months apart. Now, all those clinicians who have been practicing in this field for a while would have had multiple patients wherein they would have had a small blip wherein the patient would have had a rise of M protein. But again, you evaluate him after 1 to 2 months, you find that that blip is not there. So it's always good. It could be because of pre-analytical variables. It could be because of the various multiple other reasons, but a single reading should never be taken for starting or changing the therapy of an individual. Now, presence of extramedullary plasmacytomas definitely indicates an individual for getting starting a therapy or labeling the patient as having a relapse and then accordingly starting them on a therapy. We'll talk about it why extramedullary plasmacytoma, even a small indication of the same, indicates that a patient should go in for a therapy because there's a science behind that. So all progressions need not be treated immediately. So if a patient only has got a biochemical relapse, then it is best to observe the patient. But again, I have put a small caveat at the bottom saying that those individuals who already are known to have an aggressive disease or a high risk disease, then in those individuals, even a biochemical relapse can be treated. But barring those individuals who are being labeled as high-risk disease, rest the general garden variety myeloma, a biochemical relapse need not be treated. So the take-home message from this part of the session is that the treatment is defined by the presence of symptoms. Not all patients of biochemical relapse or progression need therapy, and aggressiveness of the previous relapse, risk of organ damage, magnitude of the M protein increase, they all play in for taking a therapeutic decision. Now, after we have decided that a patient needs to be treated, the next question comes, how do we go ahead with the treatment? So there are a few initial factors that we consider while deciding about the type of treatment. The first one happens to be the patient specific, wherein the age of the individual, the toxicity of the previous regimens that the patient has taken, any nephropathy because of the light change, or if a patient has a preference for oral versus IV. The second aspect is disease specific, wherein we need to consider what was the first line treatment and how long was the patient in remission after the initial therapy. Second, is this current relapse a symptomatic or a rapidly asymptomatic relapse or a rapidly progressive? Now, what drug classes needs to be switched based on the previous experience, use of novel agents? Third, are there any high risk cytogenetics at the time of relapse? So those are the disease specific factors. And lastly, the treatment specific factors is the duration of response to the initial therapy. A rough, broad timeline that most of us accept is whenever you have treated an individual and if his remission state was X, the remission state after we start him on the second line therapy will be X by 2. So with every subsequent line of management, the remission duration keeps getting halved. So the initial duration response is very important. Second, what is a PFS and what all treatments were previously well tolerated and which all can be reintroduced. Now, was there an insufficient response to the prior treatment because of any side effects to that particular drug rather than being resistant? And the commonly used regimens, which nowadays are more or less abandoned, that is like use of etoposide, use of VDT paste. So there were a few other regimens which can also be exploited in patients who have got resource constraints or who do not have a chance of getting enrolled onto clinical trials. Now, after understanding the patient-specific, disease-specific, and the treatment-specific factors, the next aspect is that what is the type of relapse? Is this the first relapse, or the patient have had multiple relapses, or is this the extramedullary relapse? So the relapse characteristics definitely modify the risk stratification of a patient. And based on that, we have got this is the various active drugs available as far as the multiple myeloma across the world is concerned. So those which are marked in black are the ones which are already approved by FDA, and those which are in blue are the ones which are under development. Now, if it comes to Indian scenario, if I draw the same table for the Indian scenario, all those in black are the ones which are available in our country, whereas those which are in pink are the ones which we are going to get in the near future or are currently available as part of the clinical trials. So we do have got a huge armamentarium to manage these patients. But before we decide which class of drugs needs to be advised for a patient, we need to have the understanding of what risk stratification does the patient belong to at the time of relapse. So we also have got a classification at the time of relapse as classified as high risk relapse or a standard risk relapse. So those individuals who have relapsed within 12 months from transplant or progression within first year of diagnosis will be labeled as a high risk, other than the various cytogenetic factors which are already available as part of the initial risk stratification. Now, standard risk are those who are all others, including trisomies 11, 14, and 614, will fall into a standard risk. So this brings to the aspect that whenever a patient has got relapse, it's very important to do cytogenetic analysis at that particular point of time to reclassify the patients into the risk categories. And second, the time duration of the at the point at which the patient has relapsed is also equally important. So after we understand that we have stratified the patients and the various armamentarium that we have, on today's day, the best form of therapy as far as the relapsed myeloma is concerned are either CARs or bikes. So when we talk about CAR, that is chimeric antigen receptor T-cell directed therapy, or bispecific antibodies, which are known as BiTEs. So previously, the relapse refractory, which used to have an expected OS less than 12 months, with the advent of the bispecific agents and the CAR, the survival has drastically improved from this particular category. And in fact, when we look at a single agent response rates, the best single response AR rates have been with the bispecific antibodies like talquetamab or elrantamab. So when we add them to other regimens, obviously the overall benefit improves with this particular type of agents. So if you look at it, we nowadays have a response rate anything above 60% with the CAR T therapies, teclistamab, talquetamab, and elrantamab. Now, when we talk about the bispecifics, so we have got different bispecifics targeting different antigens on the surface of the plasma cell and different types of the immune target. The commonest is CD3, but we have got nowadays CD16, CD56, CD48, and various other drugs, which are various other targets which are being targeted. In the same way, on the plasma cells, we conventionally used to have BCMA, but in the market, we are coming up with GPRC5D and FCRH5 as the newer antigen target. Of all the bispecifics that we have, the best available in the market are still happens to be the anti-BCMA bispecifics. So the teclistamab, which is currently available in our country, elrantamab, which is planned to be launched in our country by 2026, and talquetamab, which is yet not available. We just had few patients as part of the talquetamab teclistamab trial, which is ongoing. But otherwise, the talquetamab is still not available in our country. So these are the drugs which are available to us, and teclistamab now commercially available can actually change the way we look at the patients of RRMM. Now coming to the CAR T therapies, these are the various types of CAR Ts which are available, and of which the first three are the ones which are approved, and Idecel and Cilta-cel are the ones which are approved in US. The problem as far as the CAR Ts is concerned is not about the science behind it, but for the fact of availability in our country and the cost involved in importing these drugs. So that is the first issue. The second issue as far as cars in our country is also happens to be the availability of the GMP facilities, the turnaround time, and for the number of patients that we have, the scalability of this particular agent. So there are two trials which are coming up this year. Already one is ongoing of Origin. The second one, the ImmunoAct is planning to bring in the first half of this 2025 of anti-BCMA cars. So hopefully, with some indigenous cars being developed from the country, maybe the cost cutting as well as the GMP, the turnaround time can be actually taken care of. But as of now, for patients who are planned to be started on CAR T therapies outside the clinical trials, the patients, it has to be outsourced to another country. We do not have that in the India as of now. Now, after we spoke about bispecifics and CAR, there are some controversies or some questions which are still unanswered. The first question is, what is the best therapeutic agent? Once CARs would be available in our country, would it be bispecifics or CARs? What is the best time to introduce them? Is it second relapse, third relapse, fourth relapse? So how many drug relapses are we talking about before introducing immunotherapies? What is the best sequence? Should we give first bispecifics, then CAR, or should we give CAR first and then bispecifics? Once a therapeutic has been utilized, like let's take up, we have already used a bispecific which is targeting BCMA. The question would be, will an anti-BCMA CAR work in those individuals, or do we have to mandatorily target the switch the target from BCMA to GPRC5D or to FCRH5? Now, if CAR T was not the first line therapy, so when is it an appropriate time to collect the lymphocytes for CAR? So if a patient is being subjected to bispecific, should it before subjecting to bispecific or after subjecting to bispecific? Because a patient might lose those targets by the time we give the bispecifics, and the CARs that we are collecting, that's the lymphocytes we are collecting for the CAR, will they be efficient enough to incite a response for the CAR T? So these are all those questions which are still research questions which need to be answered before we understand how to integrate the various immunotherapies in our day-to-day management. There are few trials which have been presented at ASH 2024 on sequencing these and using them together or using them in tandem. So the data still needs to be mature enough to put it into the clinical practice. But yes, definitely in ASH, people have spoken about shifting this CAR and the bispecifics from a triple refractory to an early relapse, maybe the first refractory or second refractory, or in fact, they are being spoken about integrating these two agents at the time of diagnosis or in newly diagnosed multiple myeloma. So these are the various trials which have spoken about use of CAR in the earlier timelines. But when it comes to the Indian scenario, so coming to the Indian scenario, as of date because of non-availability of the cars. So it is still the bike which is pulling the car. So with the bikes being available, almost around 60 patients have been transfused with bispecific antibodies, that is teclistamab, across various centers in our country, and the results are quite enthusing. So in the real world setting, as of now, the bispecifics take the lead, followed by there are few centers which have started doing CAR-T as part of trials, and ADC has almost had its own natural death with not too much of data coming in front of it, and with the various side effects which are involved in it. So that is how the real world settings are taking place, and these are the various complications of the CAR and the bispecific. But if somebody asks me that how do we try to put them together, so this is something which would be the future treatment paradigm. So rather than transplant, people would replace transplants totally with CAR-T therapy, and the bispecifics, rather than giving the the daratumumab as a maintenance, where people used to talk about monoclonal maintenance. So future would be wherein people would be subjecting patients only to bispecific maintenance. And in frail individuals, bispecifics, probably the way the data is being presented in the ASH 2024, it is not a long way away wherein bispecifics might become upfront therapy along with monoclonal antibodies for the frail individuals, followed by maintenance with bispecific. But this is what is probably going to happen around 4 to 5 years down the line. Now, after we have spoken about the broad principles of defining, treating, and utility of the bispecifics and the CARs, the next aspect that we are going to take you is to the extramedullary disease. Now, when we talk about extramedullary disease, so if we have to classify, we can classify them into two broad groups. One is solitary plasmacytomas. Now, solitary plasmacytomas again are classified into two particular parts. One is without any marrow involvement, and second is with minimal marrow involvement. Now, somebody might ask, solitary plasmacytoma with avid marrow involvement, we don't have that category because then that would actually become a bone-associated extramedullary disease with multiple myeloma. Because as soon as we have what avid marrow involvement, that is a high percentage of plasma cells in the marrow, then it would be labeled as a case of multiple myeloma, and solitary plasmacytoma will become a B plus in a CRAP criteria, and the individual will be labeled as having overt myeloma. Now, when we say overt myeloma, so and presence of extramedullary disease, the extramedullary disease can be bone contiguous or it could be bone independent extramedullary disease. Other than the bone, the other organs such as CNS or liver can also be involved by the extramedullary disease. The most aggressive form of the extramedullary disease happens to be plasma cell leukemia. Now, if we look at the epidemiology of the extramedullary myeloma, the overall incidence of extramedullary myeloma is around 13%. Now, 7% at diagnosis and almost 20% at the time of relapse. So, the resistant clones or the mutant clones have a higher chances of leaving the adnexa or the ecosystem of the bone and migrate across to the various other parts of the body and become a extramedullary disease. Of all the extramedullary myeloma, 85% of these are bone associated, and the incidence has increased over the last few years for two particular reasons. One, we are detecting them early, and because of the routine usage of PET scans, we are picking up more and more cases of extramedullary myeloma. The second reason for increase also is because of use of aggressive agents upfront. So the mutant clones, which have a propensity to leave the bone, are actually developing. There is a study from Dr. Nikhil Munchi's group, wherein on single cell genomics, they have shown that by use of monoclonals and aggressive agents upfront, the chances of having mutant clone early is much higher. So for these two reasons, it is found that these more and more patients are developing EMD over a period of time. Now, if we look at the incidence as per the organ involved, you will find the commonest variety after we have spoken about the bone is liver, which has almost incidence of around 30%, lymph nodes almost around 25%, and other than that, less than 10%, we have got a chance of having adrenal, breast, and spleen getting involved. And I have also marked the overall survival in the side to show you that once a patient is being labeled as having extramedullary disease, the survival actually dwindles down to months. Now, these are few case vignettes to show you about how these individuals can come and present different other specialities. But when you evaluate them aggressively, you'll find that these are those cases of previously it used to be known as macrofocal multiple myeloma, but as per the current definition, it would be a bone contiguous extramedullary disease. This was another patient who was being evaluated as a case actually of a primary bone tumor. So he was labeled as a case of osteosarcoma because of the sunburst appearance. But later on biopsy, it came out that this was actually a plasma cell dyscrasia. Now, this was one of those patients who had recurrent episodes of these skin lesions. And on biopsy of these skin lesions, we found out that this individual actually was a case of extramedullary disease. Similarly, various soft tissue masses, so paraspinal masses, liver involvement, or this was one of those patients wherein he was actually labeled as a case of plasma cell dyscrasia because of the lytic lesions of the skull, PET showing multiple avidity, and he having various skin lesions. But to our surprise, when we actually did a biopsy for this, this actually came out to be an adenocarcinoma. So it's also important to understand that every lytic lesion is not or a plasmacytosis is not a case of myeloma or extramedullary disease. This is a case of hepatorenal syndrome, a myeloma presenting as a fatal hepatorenal syndrome. So this patient had a huge mass on the right hand side, you'd see on the right shoulder, also in the liver, and the spleen was enlarged, and the patient had got, he came to us with acute liver failure, and on evaluation, it was found that he not only had a myeloma cast in the kidney, but also he had got cast in the liver. So, coming to the etiopathogenesis, there are various reasons for developing extramedullary myeloma, from high-risk cytogenetics to having the duration since diagnosis, presence of circulating plasma cells, history of allogenic transplant. But to put it together, there is no reason for a myeloma cell to leave the bone and to go outside. So, but it occurs when there's a down regulation of the adhesion molecules or the tetraspanins, and there is an activation pathway for angiogenic cytokines which try to move these particular plasma cells into the circulation. So people have tried to study the immunophenotype and the genetics of these particular things. So extramedullary disease with a high proliferative index, low P27, higher P53, BCL2, BCL-XL expression are those which have a high chances of leaving the marrow and becoming extramedullary in nature. Though the cytogenetics are not well defined, it is seen that the high-risk cytogenetics are commonly associated with EMD, and gain 1Q is associated with inferior outcome. Now, they can have myriads of manifestations depending upon which organ are they affecting. And if you see a patient with a cardiac involvement will present like any other case of a heart failure. A patient of liver involvement will present with hepatomegaly, jaundice, ascites, pulmonary liver failure, or with mildly elevated transaminase. So the clinical features depend upon which organ is involved, and depending upon the organ involvement, the presentation could vary. But what is important to understand is in a diagnosed case of multiple myeloma, a patient having any organ specific clinical features, it's better to rule out a extramedullary involvement rather than thinking of a second disease simultaneously. So the Occam's razor definitely works. So, and it's good to use PET CT for follow-ups because that will be able to pick up avidity, and on a histopathological needling of that particular lesion, avid lesion, it would be easy for the pathologist to label whether the patient has got a second disorder or is it an extension of the same disease. Now, this is how we routinely talk about the myeloma treatment paradigm and the way the tumor burden is. So when we talk about the same for the plasma cell leukemias and a bone contiguous EMDs, so the presentation itself is aggressive because of a high tumor burden, and with every relapse, the tumor burden keeps increasing, and the overall duration shrinks. So this is how we manage we look at the tumor burden. And when we look at the solitary plasmacytomas, the tumor burden is much lower from the beginning to the end. That's why if you look at the treatment, even in transplant eligible patients, the upfront therapy happens to be radiation plus minus induction, followed by consolidation and maintenance. So transplant is something which can be delayed in patients with solitary plasmacytoma. Now, radiation therapy, this is one of those locations, areas wherein radiation has got a huge impact. So the treatment of choice remains to be radiation for those patients who have a solitary plasmacytoma without a marrow involvement or with minimal marrow involvement. Now, CNS disease, the craniospinal irradiation might have a limited role in isolation, but as an adjunct to a chemotherapy or along with some other form of myeloma directed therapy, the craniospinal irradiation really has got a wonderful outcomes. Now, when we look about the systemic therapy of the myeloma agents, it's not that the same VRD would work equally for the patients with extramedullary myeloma. The conventional dictum is extramedullary myeloma should be managed like lymphomas. So that's how the chemotherapy agent should be looked into. But among the myeloma directed therapies, pomalidomide, ixazomib, monoclonal antibodies have got a better outcome when compared to the rest of the agents. And when we use combination chemos, the various combination chemos, which more or less have been left out by the people across the country, are the ones which benefit a lot in this particular area. So cyclophosphamide is a wonderful agent in various combinations. Etoposide and anthracycline works wonderfully. So if you look at these combination chemotherapy regimens, you would understand that more or less they are those which are the ones which are routinely, the agents are the ones which are routinely given in lymphomas. Now, coming to the management of the organ specific, so depending upon which organ is involved, the respective treatment can be done. But to summarize the last two slides, so the stem cell transplantation, the benefits in patients with EMD appears to be limited. They have a comparable PFS but poor OS when compared to the other routine myeloma patients. There is no clear benefit of tandem transplant over single transplant based on the EBMT studies. And they have a very high incidence of EM relapse even after the patients are subjected to transplant. And a relapse with EMD can occur 54% after transplant, single transplant, 47% after tandem, and 30% after autoallogenic. This is a prognosis. They are an indicator of a poor prognosis. So any patient having EMD at diagnosis or at the time of relapse, these are those patients who will not do as well as other patients. And in fact, there was a study which was done from PGI wherein it was shown that all those patients who had a EMD had a lower survival when compared to those who do not have EMD, both at diagnosis and at the time of transplantation. So there are different types of extramedullary disease. So one is extramedullary myeloma, one is solitary plasmacytomas, and the last is plasma cell leukemias. And you would see that the survival of the plasma cell leukemias is much lower when compared to the others. And the median OS is hardly 24 months after a primary cell leukemia, plasma cell leukemias. But even these numbers are much higher numbers. These are Western based. I hardly have seen till date any PCL in my practice, at least crossing a year of therapy. And despite of whatever aggressive forms of therapy that we give, they fare very poorly. So I end here and I open up for any queries on questions. And lastly, I would just want to invite all of you for the Indian Myeloma Congress at Kolkata and also to be part of the various journal clubs and the journal scans every fourth Thursday that we are holding. And thanks for listening, your patient hearing. And I'm ready to take if there are any queries. Thank you. Thanks a lot.
Thank you, Dr. Uday, for that wonderful talk. And your talk especially makes the audience tight till the end because you're a wonderful speaker and wonderful auditor you are. Thank you so much, Dr. Uday. And I now request all of our discussants to please put the raise hand sign so that we can start our question answer session with Dr. Uday. Dr. Uday, can you please unshare your screen first?
Yeah, sure.
Yes, ma'am. Dr. Ruchi Khanna, you have a question?
Thank you, sir, for a wonderful presentation. It was so nice to hear from you. Sir, I just had a query. What is the role of next generation sequencing in early detection of refractory myeloma?
Ma'am, it's a wonderful question. So NGS, there are a lot of data which is coming up as far as the role of NGS is concerned. Now, I'll give you a quick look into this. So Dr. Parth Shah is the one who has worked maximum on NGS as far as myeloma is concerned. So the fish that we talk about has got various inherent lacuna. So it's better to do NGS when compared to fish for prognosticating. But there are two aspects to it, ma'am. When we say this statement, at the same time, I would also like to say applicability to resource constrained settings like ours is one limited. As such, fish itself, we are not getting appropriate results other than the institutional practices because of lack of plasma enrichment, the pre-analytical variables. Now, when we talk of NGS, it would be further problematic and it would add a lot of cost to the patient at upfront setting at the time of diagnosis. But once it becomes routine and we have it in a cheaper form, it would be wonderful to integrate NGS into myeloma settings. It definitely has got a huge chances to change the way we look at the prognosis.
Thank you, sir. Another query I had was, does autoimmunity play a role in the development of refractory myeloma? Is there any correlation between autoimmune disease and myeloma progression? Something like that?
Yes, ma'am. So there have been few studies which have spoken about the immune progression from a smoldering to overt myeloma and overt myeloma to relapse refractory. But these are all from the research or from the bench side. Now, putting them to the bedside to exactly say a patient having autoimmune antibodies, will they have a role or not? We do not have any data to suggest the same. But it's definitely immunity is the one which plays in progressing in a individual, particular individual. So that's how we have inter-individual variabilities. So immunity does have a role to play.
Because sometimes we encounter a patient having an autoimmune disease and a myeloma, so I was wondering whether there's a correlation or not, sir.
Ma'am, all autoimmune disorders are prone to develop hematological malignancies because they all excite our lymphocytes.
Yeah.
So the lymphocytic disorders are generally found to be higher, and plasma cell is nothing but a mature lymphocyte which gets transformed to plasma cell. So scientifically speaking, it does have a role to play, but to utilize that and to start screening every patient with autoimmunity for hematological malignancies aggressively or proactively is something which I'm not really sure.
Okay. Thanks a lot, sir, for a wonderful presentation. Thank you.
Thank you, ma'am.
Thank you, Dr. Ruchikar. Dr. Uday, there is one question related to DARA. If you're using upfront DARA during induction in any patients of myeloma, is DARA maintenance of any benefit afterwards?
In fact, all the trials which have been done till date, it's not the fixed duration DARA that we give pre-induction or the pre-transplant only in the induction phase. The maximum benefit is ideally because of DARA being given as a maintenance till the time of relapse. So if we remove the maintenance arm of DARA from all the clinical trials, so the actual benefit of PFS benefit that these trials have shown will get cut down. So DARA definitely has a role, scientifically speaking, in maintenance of a patient. So that is the ideal agent to be given. But all said and done, even in US, it's not possible to keep a patient on DARA maintenance outside clinical trial till the time of relapse because of the various financial constraints. So science, yes. Finances, no.
True. And another second question is, if the patient did not receive DARA any time and now relapses after 10 years, and now you're putting with a DARA-based regimen, again patient goes into remission, should we go for DARA maintenance in such setting?
Yes, we should.
Thank you. Dr. Satish Kumar, your question.
Yeah, thanks, Dr. Amit. Thank you, Dr. Uday, for that wonderful presentation. Difficult topic, difficult disease to manage. So I have a couple of questions, Dr. Uday. So once a patient is exposed to, say, standard RVD and DARA because of high-risk disease, did a transplant, did well, maybe he just received lenalidomide and bortezomib maintenance, and he relapses after 2 years. So would you consider adding carfilzomib and pomalidomide, or with the data available right now, would you switch to bispecifics or CAR T cells?
Very good question. Excellent question for day-to-day practice. So if the patient has relapsed after 2 years after the transplant, I would like to still not put him on a bispecific right away. I would still try to give him alternate agents by switching the type of agent. And if the patient, as you said, he received a BOTI and LEN maintenance, So then we will have to look at some other agents other than two. But generally, most of us, despite of the high risk disease, we are giving single agent maintenance. We are not giving double agent maintenance. So that gives you still an option of changing the other class of therapy. But practically speaking, I would still go ahead and try the other agents like carfilzomib, pomalidomide, or DARA also, because the patient has not received DARA for 2 years, because the patient was on 2 years of maintenance. So I would like to give these agents before I shift to a bispecific, because we need to understand two things. Bispecifics, we are not really sure about the duration or the length of the therapy for how long we should give. And second, most of us use bispecifics as a bridge for a second transplant. So is the patient transplant eligible or not? And what after bispecifics? So considering that, I would like to at least push the bispecifics a bit and try the other agents and maybe monoclonals again before taking him up for bispecifics at this stage.
Right. Right, doctor. I mean, I also thought of the same thing. The second question is about your experience with bispecifics. So with the CAR T cells taking time and difficult access, I think most of us in refractory patients, we will prefer bispecifics compared to CAR T cells in the first, second line or whatever refractory disease. What is your experience with bispecifics? So my question was about the duration only in these refractory cases, because the recommendation says something, but it's very difficult to give the doses because of high rate of infections. So what has been your experience with bispecifics? What are the complications? What prophylaxis have you given for infections? And do you give IVIG every monthly? And how long have you given? Have you shifted from this recommended dosage to only monthly once maintenance, or do you give the recommended maintenance outside trials?
So again, a very good question, practical question. So total across the country, I'll also give you the data for the country. We have summarized the data from the country. Total 53 patients have been given bispecifics around 2 months back. Now probably it's gone up by another 4-5 patients. Now, when we spoke to all the people who have been giving bispecifics across the country, we are in fact coming up with the guidelines from Indian Myeloma Academic Group on the role of infection prophylaxis or in the patients who are being subjected to bispecifics. So in Indian scenarios, one, most of us, we do PET scan before starting bispecifics. That helps in two reasons. One, it exactly tells us the status of the patient's relapse status, how much extramedullary, what is the status of the relapse. Second, it also tells us, is there any focus of infection, particularly tuberculosis or any fungal infections? Because most of these patients who are being taken up for bispecifics have already been heavily treated. And there is also data to show that giving monoclonals along with bispecifics increases the chance of infection. So for that reason, to understand any baseline infections, PET also helps out in ruling that out. So first point is doing PET for most of the patients before starting bispecifics. Second, as you rightly brought out, IVIG prophylaxis. So do the guidelines suggest giving IVIG from the second month? But in our country, it's very important, I feel, that to give IVIG prophylaxis for at least do a immunoglobulin profile, take a cutoff of 400. Though people have used 600 and 800 as cutoffs, but at baseline, to take a cutoff of immunoglobulin G less than 400. Now, also it needs to be remembered, patients can have fallaciously high IgG in a patient with IgG kappa or lambda disease. So we need to subtract. There is a way of calculating what is the functional immunoglobulin in these patients. So we subtract the M protein, M spike, the immunoglobulin G from the overall IgG, and the subtracted amount, if it is less than 400, then these patients would benefit from IVIG prophylaxis. We give monthly prophylaxis. So every month, 400 milligram per kg body weight for at least for the first 3 to 4 months is what we practice. But in our practice would be slightly different from commercial practice, because in my situation, patient doesn't have to pay because I'm from army. So they get it free of cost. So in commercial practice, people can modulate based on the finances available. Now, third, vaccinations extremely important. Though people say that a patient who is suffering from myeloma aggressive disease, vaccines might not work, but it does work. So vaccines not only work from the lymphocytes and the plasma cells, there are various other T and B crosstalk because of which vaccines work. So from the COVID data that we have from the various parts of the world, it definitely shows that a patient who is vaccinated works well. Now, ciprofloxacin or fluoroquinolones is something which we are not advocating. because of high incidence of gram-negative septicemias across the centers in our country. So we do not advocate giving fluoroquinolones or ciprofloxacin or levofloxacin for these patients. We all advise acyclovir 400 to 800 milligrams once a day, depending upon the renal functions of the patient. And lastly, we do advise that everybody who has got a fever or who have got any evidence of sepsis or SIRS in these patients should be subjected to respiratory panel also, other than the routine evaluation of the cultures and everything. So a respiratory swab, because when we summarize the Indian data, the maximum deaths have occurred because of respiratory syncytial virus. So it is the respiratory viruses which have caused the maximum mortality, not bacteria and not fungi. So RSV or doing a respiratory panel from the respiratory swab would be good, and starting antivirals accordingly. So this is how we take care of the infections. But as you rightly brought out, the biggest challenge of giving bispecifics is infections. So we are not really worried about ICANS, or we are not worried about the CRS, because most of us are now tuned to handling CRS after the COVID era. But infections is something which can actually kill the people. So we should be very careful.
And the duration, Dr. Uday?
That is one question. None of us have an answer for that. So we at least try to push them for a second transplant. So we try to bring them into some sort of remission and get the disease under control. And as soon as the patient's disease is under control, thereafter we try to push them into transplant. And those who are transplant ineligible or aged above 70 years of age, therein, though offline, I cannot say it officially, but we try to reduce the dose and bring them into some sort of maintenance with bispecifics, though not officially quote unquote maintenance, but try to decrease the dose of that Indian jugaad of trying to bring it down and give it once a month at a lower dose or once in 2 months. So we try to do that.
Yeah, that's what a lot of people suggested. Yeah, thank you so much, Dr. Uday. The third question is about what would be your choice for extramedullary plasmacytoma, not a solitary one, extramedullary myeloma and plasma cell leukemia. So if a patient comes, what would be your first choice, Dr. Uday?
So we would go, at least I would go ahead with a DARA combination, a monoclonal antibody upfront for these patients is the first thing. But second, simultaneously, the backbone I would prefer to use a combination therapy, either DCEP or VDT paste sort of thing. It all depends upon also about the performance status of the patient. So if he is a fit patient, I would definitely like to give him a DARA combination with paste. Rather than VDT paste, a DARA paste or a DARA DCEP sort of thing, or DARA VAD therapies that we used to previously give, bortezomib, anthracycline, and dex. So some where I would be able to give cyclophosphamide and anthracycline in combination with a monoclonal is something which I would like to do. But these are those patients where I would, rather than doing 3-monthly monitoring, I'd like to do a monthly monitoring, because as soon as the patient comes into remission, I would like to push him into transplant immediately. So I won't wait for that conventional 3 to 6 months for taking the patient up for transplant.
And you would prefer autologous only for both plasma cell leukemia?
So we have actually, from Army, we are the ones who have the highest experience for allogenic transplants in myelomas. So General Nair used to start it, and we all followed his footsteps. So we do have a fair experience and success with allogenic transplant. But the challenge that we face in such patients is for finding a donor for a allogenic, because when we are looking at transplanting within 1 to 2 months, getting a appropriate donor is a challenge, and we really don't know what is the benefit of haplo. So considering that, allogenic transplant, getting a mud or a match sibling donor is something which is there. But yes, we have tried in 2 or 3 patients wherein we gave for plasma cell leukemias allogenic, and the patient doing well. So the way we would think otherwise is, because of the time constraints and the performance status, maybe autologous, and thereafter monitor the patient. And at the first sign of progression, not relapse, at the first sign of progression, to work him up actively for a allogenic. So we have done this auto-allo. I will not call them tandem, because in tandem it's pre-planned, but autologous initially followed by allogenic. So we almost have 6 patients who have been taken up like that.
Right. Thank you so much, Dr. Thank you.
And any role of venetoclax in plasma cell leukemia if found to translocation 1140?
Yeah, so that's why you answered it. So if the patient has got translocation 1114, definitely yes. But in the absence of that, we really don't know. But all said and done, these are those patients where most of us are pushed to the corner as hematologists or oncologists. So we try to do whatever is available at our hands. So if the patient is not faring well, so giving venetoclax as a last resort is nothing wrong.
Thank you. Another question has come from Dr. Govind Patel. What is the incidence of CNS myeloma? How many cases of CNS myeloma have been encountered in your clinical practice? And how do you treat this entity?
So very difficult question to answer. The reason being, I really do not have statistics for CNS myeloma. But yes, I have seen one. So it's anecdotal. So we have seen one patient at where when I was a fellow in PGI and one in my practice thereafter. But the second patient whom I saw, by the time we diagnosed him as CNS myeloma, he expired within 2 days. So really, we didn't have the time to manage that patient because he was actually being managed as a case of sepsis and septic encephalopathy. But when we got the flow cytometry positive for the CSF for the plasma cells, by the time it was too late. So that's first part of the story. Second point is how do we manage such patients? So definitely those agents which have got a CNS penetration, but all said and done, this is one of those entities which have got extremely poor prognosis. So cranial irradiation, craniospinal irradiation will buy us some time. Along with that, methotrexate and cyclophosphamide, which have got penetration across the blood-brain barrier, are few of the agents wherein it might help. But exact standard guidelines about how to go about in a given patient depends upon multiple other factors.
Thank you. Another question has come from Dr. Gopinathan. A 70 years old male received post 12 cycles of VRD and now relapses again. What would be your management now?
So this would be like what we discussed with Dr. Satish just now. So the points would be we would like to look in whether the relapse occurred while because most of us won't give for 12 cycles a full dose of VRD. So probably after a few cycles, we would have definitely shifted him to a lower dose if the patient would have gone into remission. And if the patient was not in remission even at 12 cycles, then it would be a primary refractory rather than calling it as a relapse. And in such situations, we'll have to, if we label it as refractory, we'll have to change both the agents. If we are calling it as a relapse, we can still try to see that which agent he responded best and try to reintroduce that agent. So in this particular patient, maybe a change of both the agents, bortezomib as well as lenalidomide, would be suggested. So I would add daratumumab first thing in these patients. And second, carfilzomib, pomalidomide are the things which are in our hands to modify with. So one of those agents along with daratumumab. So Dara Pomdex, Dara Body Pomdex, or Dara Carfil Pomdex, something like that. Dara KPD.
True. Thank you. Another question is, which has come from the audience. The patient who is 65 years male, newly diagnosed multiple myeloma with grade 4 neuropathy. And this is motor neuropathy as well as sensory neuropathy. How would you manage this? What would be upfront treatment of choice? How many cycles? What regimen? Etc. etc.
So what you are saying is a patient is having AMSAN. So there are two things which needs to be done in such a patient other than the conventional therapy that we talk about. So bortezomib is one particular drug which I would be really careful in such a patient because it might worsen the neuropathy in these patients. Second drug which I would be careful about is thalidomide. So bortezomib and thalidomide I will be careful. So I will prefer going for carfilzomib, and by next year this time we'll have ixazomib in our country. That would be the ideal agent for this particular thing. So maybe carfilzomib because of lower chance of neuropathy along with lenalidomide dex would be the upfront therapy of choice. Now, also, please, I would like to advise for such a patient to undergo a nerve biopsy because if we find that this particular patient has got a light chain deposition, then it would be reversible and we can advise the patient for aggressive therapy for this. If there are amyloid deposits, the prognostication of the patient would be different, wherein I will have to tell him that my therapy will be preventing progression but not remission of these particular neurological findings. And also, There is something known as a monoclonal gammopathy of neurological significance, wherein patients can have poems, patients can have various other neurological, particularly CIDP type of picture or AIDP type of picture secondary to the myeloma. Those are the ones where there is some role of having a high cutoff dialysis or having a plasmapheresis. So aggressive evaluation other than just management would also be helpful in such a patient.
Absolutely. Thank you so much. There is one question which has just come for Dr. Ruchira Mishra. Are you there, Dr. Ruchira, ma'am? Dr. Ruchira Mishra, are you there? Okay. In that case, fine. So there are no more questions from the audience. Any discussion want to ask any other question? Well, in that case, Dr. Uday, there are no more raising signs and there are no more questions in the audience. Well, thank you so much for that fantastic lecture as always. Always good to hear from you. The way you speak, you are so confident. What a good orator and speaker you are. Thanks a lot. Dr. Ruchira, one question has come from Dr. Gopinathan for you.
Sure, sir.
So his question was regarding the dose of grafilon in case of haploidentical transplants.
So initially Graflon started and they advised 30 milligrams per kg, which was 10 milligrams per kg given over 3 days, 10 milligrams per kg per day. Gradually we have learned to give smaller doses. So we ourselves have used 7 milligram per kg over 3 doses. So 3 days so we've done 21 milligram per kg. But I know of other centers who've also done 50 milligram per kg. So that's why we are kind of decreasing the dose and still trying to see whether it is still beneficial or not. And 15 seems to also work. So you could try 15 and see whether it works for your patient or not.
Thank you. Thanks a lot. So in that case, once again, thank you so much, Dr. Ruchira Mishra, for your first session. All the panelists, as well as the talk, as well as I also thank Dr. Uday Yanamudra for the second lecture. And I thank all the discussants, as well as audience to participate in this long webinars, 2 sessions, long ones. Thank you so much and meet you tomorrow at 11:30 a.m. sharp with another beautiful webinar. Thanks a lot for now. Goodbye for now.
Thank you so much. Good night.
Bye.
Thank you. Good night.
Good night.